what's up everybody? Welcome back to my YouTube channel. Today I'm super excited to chat with you guys because we're going to be talking about the use of a baby aspirin or low dose aspirin in order to prevent preeclampsia and why we as OBGYNs recommend it. First, let's do a couple house cleaning things. If you guys watched my last video, you know that I am newly pregnant, not even newly, just newly announced. I am 24 weeks pregnant with my second baby, and you guys know that with my first pregnancy with my daughter, I ended up being high risk. I did develop severe preeclampsia. I had growth restriction, or my daughter was growth restricted, and she had oligo, which means she had low fluid, and I had to deliver a month early via C-section because she was breech. So it was just kind of a lot that pregnancy. One of the questions that I've gotten is, what am I doing differently this pregnancy, or what am I doing to help prevent myself from getting preeclampsia? So one of the most common questions is, why do we recommend baby aspirin? Before I get started, I want to do a couple housekeeping stuff updates for you guys. So like I said, I'm 24 weeks pregnant. I'm feeling so much better. I really struggled with nausea and vomiting in the beginning of the pregnancy up until honestly like 20 weeks. Then I had a stretch of like a good week at around 20 weeks where I wasn't nauseous, and then it kind of came back. Now I've had a couple really good days and I'm feeling so much better, but it's just been rough. I just don't like being pregnant. One of the other videos I'm going to make is on mental health in pregnancy and my personal struggles, and then I'm also going to make a video about C-sections or TOLACs, VBACs. What am I doing? Am I going to try for a vaginal delivery, or am I just going to have a repeat C-section? So all that good stuff is coming. I promise to stay tuned. Also, since I have you here, I did want to try on the Biggs jumpsuit. So this is the breastfeeding collab that they do every single October. And I love their jumpsuits, but the ones that I currently have do not fit the belly because they're mediums. So I ordered a size large to see how it would fit. So I wanted to try it on. This is the Raffaella Cargo Scrub jumpsuit. And like I said, I got a size large. I think it's gonna fit. Let me go try it on and I'll be right back. I apologize, this room is a mess. This is what used to be, or currently still kind of is, my office and Corey's office where I film a bunch of my videos. But because of the second baby, this is going to be their room and playroom. So we're currently in the process of like moving the desks and stuff to another room. So it's kind of a mess in here. But this is the jumpsuit. It's still, once I get bigger, it's going to be a little too tight. But for right now, this is actually really cute. I really like it. You guys know I love a good jumpsuit moment. Romper onesie. It's cute. And of course, it's breast cancer awareness. Make sure you're up to date on your screening and that you're doing self-screening on yourself every month. Now let's jump into the video. Low-dose aspirin in pregnancy. Why do we recommend it? We recommend low-dose aspirin that's 81 milligrams. It's the same thing as a baby aspirin, and it's used to prevent or delay the onset of preeclampsia. Now, does everyone need to take this? No. So we're going to quickly define and specify what patients qualify and are recommended to start a low-dose aspirin in their pregnancy. This is going to be a recommendation that is approved by ACOG, or the American College of OBGYNs, but also by the US Preventative Task Force. So they came out with their list of criteria, and then ACOG as well, and so they both recommend it. So first and foremost, they recommend starting a baby aspirin in the late first trimester and to continue it through the remainder of the pregnancy, and that's going to be taken daily. This is going to be for women with a history of preeclampsia who then also delivered early, so 34 weeks or less. Other criteria is women who had a pregnancy that was complicated by high blood pressure or preeclampsia in a prior pregnancy. And there's also a more expansive criteria list, which I'm going to go through. But if you have several of these risk factors, then it's definitely important to sit with your doctor and see if you qualify to start taking a baby aspirin or what their recommendation is. Let's quickly go through that list. I'll also put it up on the screen so you guys can follow along. I have the list in front of me on my iPad, so I'm going to go through it. But essentially, this is the recommendation to start a low-dose aspirin if the patient has one or more of these high-risk factors. So if you have one of these or more, you're going to want to start taking it. A history of preeclampsia, multi-fetal gestation, so twins or higher order pregnancies, chronic hypertension, meaning you have a history of high blood pressure outside of pregnancy, type 1 or type 2 diabetes, renal disease, autoimmune disease, specifically systemic lupus erythematosus or antiphospholipid syndrome. Now, these are going to be the list of moderate risk factors. So you should consider starting a baby aspirin in these patients if they have more than one of these moderate risk factors. So one of them is nulliparity, meaning this is your first pregnancy. Obesity, meaning you have a body mass index or a BMI that's higher than 30. A family history of preeclampsia in your mother or your sister. Socioeconomic demographics, such as being African American or Black, or having a socioeconomic status. What's interesting to note when we start talking about being African American or a Black race, this is actually a proxy due to racism found in medicine. We know that there's underlying racism. We know that the maternal mortality rate is higher in those that are Black and African American. So definitely talk about that for much longer. If you want me to, I can address it in another video. Next is age 35 or older. And another thing is going to be a personal history. So you have a personal history of low birth weight or small for gestational age baby, previous adverse pregnancy outcome, or more than 10-year pregnancy interval. And then the criteria for low risk is, in which case we do not recommend that someone start taking a baby aspirin, is someone with a previous uncomplicated full-term delivery. Now, when they made research studies looking at whether or not taking a baby aspirin is going to be beneficial, how we know that it helps to prevent or delay the onset of preeclampsia, they looked at other things that a low dose baby aspirin may help in. So some of these things is they look to see that if taking a low dose baby aspirin is going to help people with a history of fetal growth restriction, or what used to be called IUGR, they looked at it for people who have early pregnancy loss or recurrent early pregnancy loss to see if it would be beneficial. They looked and checked against stillbirth or someone with a history of a stillbirth, or someone with a history of just strictly going into preterm labor and delivering early. Now, as of now, ACOG, because of that previous research that was done, does not recommend starting a baby aspirin just because of those reasons. Right now, it's strictly only going to be recommended for those with a history of high blood pressure and then obviously all those risk factors that we talked about. I know right now through my friends that are in REI or the ones that are reproductive endocrinologists and deal with infertility, there is some noise and movement and research being done on women that have recurrent pregnancy losses or early like first trimester pregnancy losses and the benefit of starting a baby aspirin. So I'd be curious to see if the research changes after, you know, we obviously research it more and see if there's more harm than good and when to start it. But I've definitely heard things in the pipeline, so I'd be curious to see how that changes or if it does change. Now, the recommendation is to start taking the baby aspirin at 12 weeks and not sooner than that. Ideally, if you can start taking it between 12 and 26 weeks, that's going to be the best time, ideally before 16 weeks, but not earlier than 12 weeks. So definitely these are conversations that you should be having at your first appointment when you go in for your first OBGYN appointment when you found out you were pregnant. This would be the best time to have this conversation because usually we try to make those appointments anywhere between like 6 and 10 weeks when you get that first ultrasound. So definitely bring this up with your doctor to see if you should start taking it at 12. Obviously, I'm an OBGYN and I have a history of preeclampsia, so like check. I qualify to start taking a baby aspirin, but I also have some of these criteria, like for example, I'm older than 35, check. I have a history of a growth restricted baby, check. What else? Family history of preeclampsia? No, I do not. My mom never got it and none of my sisters have been pregnant yet, so let's see, what else? I think that's it. Based on that, I qualify and it's why I take it every day and I have been since 12 weeks. I want to quickly go into what is aspirin and why does a baby aspirin work? Why don't we increase the dose? How exactly is a baby aspirin helping to prevent or delay the onset of preeclampsia? It might get nerdy here for like 2 seconds, but please follow along because I think this is pretty important. So aspirin. Aspirin is a cyclooxygenase inhibitor or a COX inhibitor, so COX COA, much easier to say than cyclooxygenase. It also has anti-inflammatory properties and antiplatelet properties. So essentially, when you start talking about cyclooxygenase, there's going to be two of them that aspirin inhibits. So it inhibits COX-1 and COX-2. Now, both of these, COX-1 and COX-2, are going to be a necessary part in the biosynthesis of prostaglandin. So we're going to see COX-1 is present in vascular endothelium. This is talking about vessels. So when you hear vascular, think blood vessels. And COX-1 is going to be part of the chain or a necessary component in making prostacyclin and thromboxane A2, or also called TXA2. Okay, now why is all of these big fancy words, why are they important? Now, prostacyclin, remember it's part of that COX-1 pathway that I just talked about. This is going to be a pretty potent, so a strong vasodilator, which means the vessels dilate and relax. Prostacyclin is also going to be an inhibitor of platelet aggregation, or what causes those platelets to kind of clump together and stop bleeding. Now, thromboxane A2 or TXA2 is, think of it as kind of the opposite. It is a potent vasoconstrictor, meaning then the vessels can close up and get tight. So dilation gets wider, constrict gets smaller. Hope that makes sense. Also opposite in the sense that TXA2 promotes platelet aggregation. So it binds those platelet molecules together, whereas prostacyclin inhibits them, right? Remember? So why does this matter? Interesting is that in the studies that they've done, they know that aspirin at a low dose, so the 81 milligrams or that baby aspirin dose, causes a decrease in the TXA2 without affecting the production of prostacyclin. At a low dose, it's going to start inhibiting those TXA2 so that you're not having vasoconstriction and you're not causing those platelets to aggregate and clump together. When we start talking about aspirin at a higher dose, that's going to inhibit all of it. So it's going to inhibit the TXA2 production and it's going to inhibit the prostacyclin portion of it as well. But low dose aspirin only inhibits the TXA2. So what does this mean for preeclampsia? We know that the evidence shows that when we start talking about the development of preeclampsia, there's an imbalance between the amount of TXA2 that's produced and the amount of prostacyclin that's produced. So once researchers found that there's that association with preeclampsia, where women that were found to have preeclampsia were making more of that TXA2, they thought, we already know that aspirin at a low dose inhibits that production, so why not give these women with preeclampsia or with a history of preeclampsia low dose aspirin to try and block that and inhibit that production, so essentially it protects and prevents and or delays preeclampsia. So that's why we recommend it. I think that's pretty cool, and that's why I think it's important to understand why it's the low dose aspirin and why you shouldn't be taking a higher dose than what's recommended, because you don't want to inhibit both of those pathways. You just want to inhibit the one that we know has an association with preeclampsia. I know that got really medical and nerdy, so I hope it made sense, but if I can clarify it any better, let me know in the comments. Another reason that we know that just by taking a baby aspirin doesn't necessarily mean that you're not going to get preeclampsia. You still can, and that's because preeclampsia is also multifactorial. So it's not just the increase in TXA2 or that imbalance. Preeclampsia can also be caused by a multitude of different reasons. Oftentimes, we don't know exactly why some women get it and others don't. So it's just one of those things where we know the association with the preeclampsia, and there's no harm that was seen in the studies that were done, which is why it led to that recommendation, because in the studies and the women that started taking the low dose baby aspirin, we saw those decreased cases of preeclampsia. Other reasons that it can be caused, there have been studies to show that also if your partner has a history of high blood pressure or is unhealthy or has something else going on, that could also contribute to then the mom developing preeclampsia, because remember, the placenta and the baby is two of you. It's not just one person. So the paternal or the father's health can also affect or be a risk factor to someone getting preeclampsia. Other things is some women have an exaggerated anti-inflammatory response to trophoblasts, which can be found in the placenta. So that could be a reason. It can be there's a dysregulation in reperfusion or issues with the placenta. So like I said, it's multifactorial, so there can be a lot of reasons why. And in the moment, if you get diagnosed with preeclampsia, it's going to be hard to identify exactly what happened to you and why you developed it. But know that this is still being heavily studied, and I'm hoping that we get more information soon, because really I was affected by it and I don't really know why, but I was. In the studies, they obviously wanted to make sure that it was safe. So one of the things that people think about is, we know that aspirin historically, especially at a higher dose, can be viewed as a blood thinner. So then people were like, well, we don't want women to be at an increased risk of bleeding, of postpartum hemorrhage, of a potential abruption, or any complications with the fetus. And luckily, there were no adverse outcomes as far as bleeding risk, abruption risk, or increased risk of postpartum hemorrhage, which is really reassuring. And I think a lot of it also has to do with the fact that it's a low dose baby aspirin. Also didn't find any issues with the babies. So no risk of like a congenital malformation or any fetal risks were seen in the studies. And they also looked at and made sure that these babies that were exposed to aspirin in utero, that when they were born, the babies didn't have any bleeding, increased risk or anything like that. So there was no increased risk of an intracranial hemorrhage or bleeding within the brain of a baby of a mom who took the aspirin, which is good. Now, obviously, there's always going to be contraindications, just like with any medication that you start taking or procedures that you need to have done within medicine. There's always going to be contraindications. So people who should not be taking aspirin, if you have an allergy to aspirin, don't take it. If you have a history of nasal polyps, which is interesting, but there is an association with aspirin and NSAIDs and nasal polyps. So if you have a history of nasal polyps, of bronchospasms, especially associated with aspirin or NSAID use, you should not be taking it. Obviously, you need to bring this up with your doctor so that you guys can talk about it together. For people who have hepatic dysfunction or issues with their liver, with metabolism, with something with their liver isn't working right, you know this history, you need to bring it up with your doctor because you may not be a candidate to take the aspirin. Same goes with someone with an active peptic ulcer or an active bleeding ulcer in your GI tract. You probably don't want to take NSAIDs or aspirin, so definitely discuss that with your doctor, your OBGYN, or your GI doctor, or whoever's involved in your care team. Okay, I will leave links and more information specifically through ACOG or the American College of OBGYNs linked down below so you guys can get even more info. But I hope this kind of eased your mind that if your doctor made the recommendation, or maybe you didn't understand why they recommended that you start a baby aspirin, then definitely I hope that this video helped. I also wanted to clarify, why do we recommend these for people with those chronic conditions like I mentioned? Why do we recommend it with someone with diabetes, for example, whether that be type 1 or type 2? Say someone with like the autoimmune disease like antiphospholipid syndrome or lupus or something like that. And that's because we know that these conditions like diabetes can affect the vasculature, right? So we know already that people with diabetes, yes, everyone just jumps to the sugar and the insulin and all that kind of stuff, but diabetes is much more than that. Diabetes is a syndrome that's going to affect so many different organ systems throughout your body, specifically your blood vessels. That's why people with diabetes are also at increased risk for heart disease, because it affects the blood vessels and it affects the blood vessels of your heart specifically as well. So same with preeclampsia, it's an issue with blood pressure, right? That's what preeclampsia is. It's high blood pressure in pregnancy. When we talk about blood pressure, that's going to be the pressure of the vessels in our body. So if you already have a disease that has a risk of affecting your blood vessels, then that's a risk, because preeclampsia is going to only affect them more. Does that make sense? So that's why we recommend it in people with that history of things like diabetes, because you already have that first kind of insult to your vessels, or the potential, if you're uncontrolled diabetic, of potential injury to your vessels. So that puts you at a risk factor, just like I have a risk factor having a history of preeclampsia. So I hope that kind of makes sense as to why those chronic medical conditions are already kind of like a check and a risk factor to affecting your blood vessels. Alrighty, that brings us to the end of the video. I hope you guys learned something, and please let me know if I did a terrible job at explaining this or it doesn't make sense. I can try to answer more specifically in the comments, but I'll leave those resources linked down below. Also remember, make sure you're up to date on mammograms, that you're getting clinical breast exams, that you know what your breasts feel like. Even if you are pregnant, breastfeeding, young, don't have a family history, it is still so important to check your own breasts. And if you have any worry, doubt, fear, you feel something, you're unsure, does this mean something, go see your provider and get necessary testing if that's what they recommend, because we have seen such an increase in the incidence of breast cancer, especially in women who are younger and don't have a family history. So super important, and I encourage you all to go get checked out. Thank you so much for all of your love and support. As always, stay tuned because I have so many ideas and so many videos I want to film. I'm just still trying to figure out life with a baby, being pregnant, working full time, and doing social media. Thanks for your patience and your support, and I'll see you in the next video. Bye!